It's great to be here, and really great panels this morning. I've enjoyed this very much. So let me start with a few disclosures of who I currently receive funding from in the forms of research contracts. I want to begin by talking about what I view as this grand opportunity that we all have. It's also a grand challenge, but let's think of it as an opportunity. And my story begins, gosh, more than 30 years ago with this person, a person by the name of Jerry Grossman, who from about 1984 to the mid-90s was president and CEO of the New England Medical Center Hospital. And there we go. Jerry Grossman liked to tell the story about picking up the New England Journal of Medicine one day, and this is, I believe the date there is 1986, 89, something like that, and reading this paper, and calling somebody in his hospital and saying, "We're not one of those Boston hospitals that looks so bad, are we?" And the answer was, "Oh yeah, we're that." And then he looked at the date of the data, because Medicare data at the time, 3-4 years old before you could use them, right? And realized that not only was their quality of care lower, the data were 4 years old. It was the first time he'd ever seen them. So Jerry, and the conclusion of this paper was that this lower rate of use of hospital by enrollees in New Haven wasn't actually associated with a higher overall mortality rate. So I'm having trouble here. Oops. You know what? I pushed the wrong button in.
That's okay.
Okay. I will use the arrow keys and keep going. So Jerry Grossman, along with about 12 of his, there we go.
Where's the mouse? Oh, there.
I don't know.
Okay, let's try use the keyboard.
I can use the keyboard.
Okay, do you need your speaker notes?
No. We'll go with like this. This is fine.
Okay,
we're fine. So in about 1989, Dr. Grossman and 12 of his colleagues formed the Academic Medical Center Consortium, which was headquartered in Rochester, New York, and the place where I got my first opportunity to work at this nexus of healthcare delivery, improvement, and health services research. I just finished a master's degree. And at the time, I thought, this is a really interesting problem, right? Like, how do we actually bring what we learn in the research that we do, how do we bring it to bear in the way that care is delivered? And naively thought, like, oh, we've got this. Like, we can do this. We can solve this problem pretty quickly. And we worked together and actually developed some fairly, I would say, interesting and useful tools and approaches to actually measure and manage care as part of care delivery. And then a budget crisis rolled down from the federal government, and the funds to sustain this really went away. So, but my story actually starts there, and the work that we thought was so important to do remains important today. And in fact, 30 years later, we see this vision for a learning health system, and it's a vision that we talk about all the time. And for me, it really resonates with those very early conversations that we had around how do we actually bring together the data, the information, the questions, the answers to improve the way that care is delivered. I think we are so much better, in such a much better position now than we were 30 years ago for so many reasons. First, I think about the silos of information, of expertise, of data that really plagued us back then. And now we've really, I think, begun to move into an era where sharing is becoming the norm. That is more and more the expectation, that what we do, we share. The data that we gather, we share. And that's hugely important if what we're trying to do is not just learn something that we can publish, but learn something that other people can replicate and that we can use to improve care. We've also, at the same time, moved into an era where the people are at the center of our questions. And many people, many organizations have had a hand in this, but I think this might be the lasting legacy of Pakore, who almost single-handedly has pushed, I would say, the NIH to really raise its expectations about what people-centered research looks like, and how our grants and how our requests for funding should look. This group, I don't have to tell you much about the data that are now available to us and the opportunities that those bring to really put together different kinds of data to answer questions in ways that were not possible. And we also know for the last 20 years at least, every 4 years, computing power increases by an order of magnitude. So all of the pieces are there, I think, for us to really make good on this opportunity. And yet at the same time, last year, these pictures, I think, caught many of us by, if not by surprise, really kind of knocked the wind out of our sails, right? So across our country, we see that we're not actually delivering on this promise yet. There are counties, there are pockets of our country where life expectancy is really markedly lower than others, and counties where it's gotten worse over time. Some of these are pretty close to where I grew up. So I realized that although all of the opportunity is there, we haven't yet figured out how to bring it together and affect the change that we're all striving for. It's also the case that our evidence base the quality of our evidence base is relatively weak. I mean, this is an old paper from colleagues of mine at Duke, but it's almost 10 years old now. But it showed that really that evidence underlying the guidelines that are put forward by the American College of Cardiology and the American Heart Association, I mean, they're by and large not evidence-based, right? The vast majority of them are not based on solid randomized controlled trial evidence, but rather driven by expert opinion. And that's in cardiology, which has often been way ahead of the curve. And we also know that it takes way too long for what we do to actually make its way into practice. So even if we do the trial and we get the answer, and the answer is actionable, we're still then stuck trying to figure out how to get that, improve that uptake, so that in fact what we've done can deliver improved care for patients and for our communities. The cost of research is rising, and that I think is particularly problematic because it just creates more and more barriers to generate the evidence that's needed. And I would argue, too, the other problem we have now is that there's a real tendency toward favoring what I think of as disposable research rather than reusable research. I've written grants where I talk about this infrastructure that I build to answer a question, and for the 5 years of that grant, it's glorious. And then that grant goes away, and I have a different idea, and I rebuild some infrastructure, and we do it again and again. I think there has to be a better way. I think to myself, there has to be a better way to do this, and I think there is, and I have a couple of exciting things to talk to you about in that vein. I'm not the only one who thinks there has to be a better way to do this. Last year, a couple years ago now, a paper came out in the New England Journal that was co-authored by really the leaders of many of our government agencies with interests in health. So at the time, Rob Califf was at the FDA, and as you look through these names, you realize we have the FDA, the NIH, the National Academy of Science and Medicine, and the VA, and many, many more saying it's really time that we transform the way we generate evidence. And they brought forward in that some specific suggestions, right? And they included, we have to create effective research networks. This addresses specifically that disposability of the research infrastructure that we're creating. So let's create something that we can use and augment over time. Make sure that we have robust ethical and regulatory frameworks. Really adopt some common approaches to the way that we deal with digital healthcare data. Make sure that we're testing new methods and investing in the development of those new methods. And also really keep an eye on efficiency of study conduct. The graph showing what's happening in terms of the cost of research, I think, is really sobering. Unless we can figure out how to bend that cost curve, our ability to really generate the evidence that's needed really will never materialize. So my summary of the opportunity is that the opportunity is there, and all of the pieces for us to make that to turn that opportunity into reality. I think it's possible, and I thought it would be helpful to go from that opportunity then to really talk about a couple of initiatives that I'm involved in where I feel like we're working to translate that call to action into the real world. Spoiler alert, not easy, right? But all of you know that. So the two examples that I'll talk about today are, first, the work that I'm involved in with PakoreNet. And for those of you who are at CHOP or Temple and other institutions, this will be familiar to you because PedsNet is of course based here at CHOP under Chris Forrest's leadership. And the other initiative that I'll talk about that you may be less familiar with is the NIH Collaboratory. Very exciting for different reasons. So let me kind of tell you a little bit about these, and then I'll then move into talk about what I've learned from working at this nexus that I described early on. PakoreNet is the National Patient-Centered Clinical Research Network of PCORI, and my shorthand description is that it's sort of the signature investment of PCORI. This vision that brought this network forward was to have an infrastructure, a network that could really support this concept of a learning healthcare system, global learning healthcare system, and to really be able to do the kind of large-scale clinical research that's necessary to generate evidence for higher quality care. PakoreNet is really a network of networks. So as this slide suggests, there are 20 patient-powered research networks, which represent very different kinds of patient groups. Some of them more, I would say, probably a little bit more toward advocacy groups with a less robust underlying data infrastructure, but a very cohesive group of mobilized patients. And maybe at the other end of that spectrum would be patient-powered research networks with a very deep data infrastructure underneath engaged patients. There are 13 clinical data research networks, of which PedsNet is one. We have 2 health plan networks that are part of this, and a coordinating center that has 3 locations. The one that I spend a lot of my time at the Duke Clinical Research Institute, the Harvard Pilgrim Healthcare Institute, led by Rich Platt, and Genetic Alliance, led by Sharon Terry. So the three of us, those three groups come together to form the coordinating center. And really, we think of it as a community of research that brings data from patients, from clinicians, and from systems together. The PakoreNet is, some of us, those of us who spend a lot of time with data, always talk about the data first. But I'm, as I'll tell you in a bit, the data are necessary but not sufficient, as everyone in this room knows. The clinicians, the patients, the health system leaders, everyone has to come together to make this work. And the case example that I'll give is from the Adaptable trial, which is an aspirin study that PakoreNet is doing. How many of you have heard of Adaptable? A few, great. Anyone enrolled in Adaptable? Good. Well, our target enrollment is 15,000. So if I could enroll a few of you while I'm here today, I think that would be a real boon for us. So Adaptable is the first randomized clinical trial atop the PakoreNet infrastructure and is specifically answering the question about which dose of aspirin is better for secondary prevention of cardiovascular disease, high dose or low dose aspirin. Simple question, important question we probably should have had an answer to 20 years ago, right? And it's a question that we're going to have an answer to now, thanks to this trial. For Adaptable, we've used what we call this kind of enabled pragmatic research that involves e-screening, electronic screening, electronic enrollment, and electronic follow-up. So, what this slide sort of shows at a high level is how adaptable enrollees come into the trial, and that is they're approached in many different ways from the participating networks. We've used combinations. Our sites have used combinations of emails, letters, physician contact. Study coordinators, all sorts of different approaches to get to a trial with 15,000 participants in it. I can tell you the bottom line is many touches are required. So there is no magic way to recruit. The way to recruit and get people to enroll is to approach them in multiple different ways. So when the potential participant receives their invitation to participate, they go to a portal, the Adaptable portal, where they can learn about the trial, and if they're interested, they can actually go through the consent process that is there, learn about it, watch a video, take a test to see if they've comprehended what they're signing up for, and then they can enroll in the trial and be randomized via the portal. That information is provided back to the participating network so that we have a way of identifying these individuals and tracking them over time. We do track them passively through data that are captured in the PakoreNet Common Data Model, which is maintained at each of these sites. So to the extent that they're having healthcare encounters, we will see those. Healthcare encounters within participating networks, we will see those. And they also come back to the portal every 3 to 6 months, and participants are randomized in terms of to how frequently they come back to the portal. If we haven't heard from somebody, if they haven't come back to the portal within a few weeks of when they were supposed to, we follow up with them, and eventually we have a call center that can come into the mix. We're also doing linkages with other data sources to make sure that at the end of the day, we've not only answered a question, we've not only used this infrastructure to answer a question, but we really have answered the question. So making sure we have the right patient, right participants enrolled, right treatments, and complete follow-up. Adaptable's pretty different from a traditional trial. And I think this slide really highlights some of those differences. I've talked about a few of them. I mentioned that the data infrastructure for this is a common data model. There is no separate case report form. The participant fills out baseline information and provides us information about events that have occurred in the intervening period, and we certainly reconcile those with what we see in the electronic health data. It's a broad cohort of individuals. The consent is patient-directed. I talked about the e-consent. The source documents, those all stay at the site. And there's not, in terms of endpoint adjudication, we are doing some validation studies of the endpoints, but we're not adjudicating every endpoint for sure. So I think all of those really are quite different from what we see in traditional trials. Probably the biggest difference, though, is that last line around patient engagement or participant engagement. In Adaptable, the adapters, as they're called, they have been involved in protocol design. They're involved in committees. They're actively involved in dissemination. We had a live Facebook event at the American Heart Association last year that was co-hosted by our adapters, and it was just both phenomenal and inspirational, and really generated a lot of good buzz that led to spikes in enrollment. So all good things. I'm especially proud to say that we've enrolled over 9,000 participants to date. Now that's a really, really big number, right? In traditional trials, it's not uncommon to have a site enroll a patient, a participant every 2 weeks, right? That's not bad enrollment. That might be good enrollment, right? And I'm talking at Duke. That might be really good enrollment at Duke. In Adaptable, we have now enrolled 1,100 patients in Adaptable. It's a huge number, and that's been a lot of work for all of the sites. So that's my PakoreNet and Adaptable experience, right? Really, how are we trying to respond to this call to action that was put forth and continue to move forward toward generating evidence using data and by bringing people together. The other example that I want to at least tee up before I talk about kind of my learnings in the work that I've been doing is the NIH Collaboratory. How many people here are familiar with the NIH Collaboratory? Just a few. Okay, great. So the Collaboratory was initiated through the Common Fund in 2012. And as you may know, the Common Fund really is, I think of it as sort of the director's fund, right? Those are centrally held funds that are used to really get novel initiatives off the ground. And what the goal of the Collaboratory was to strengthen our capacity to really do cost-effective, large-scale research studies that are embedded in healthcare delivery. I think the ultimate vision was that we would learn through the Collaboratory how to do these so that eventually we could do these so much more easily and more cheaply, and again, generate more and more evidence at a lower cost. When we talk about embedded pragmatic clinical trials, we're really talking about those kinds of studies that just mash up research into clinical care, and all of the tensions that exist when we do that are present in these embedded studies. These studies are designed with actual input and health system leaders at the table. Often the data are collected using via the electronic health record, or that becomes sort of a foundation for data collection. The interventions that are delivered have to be incorporated into routine clinical workflows, which is, as you know, no small feat. The patient populations are often quite broad and diverse, and the outcomes have to be those that are important to decision makers, because in order to get the buy-in from the health system leaders who are allowing these studies to go on, it has to be an answer that they need and that they want. The Collaboratory is a little bit different in structure from other kinds of initiatives in that we have these demonstration projects that are funded to answer important questions and to provide evidence about what works in terms of doing pragmatic clinical trials. So we are specifically tasked with making sure that we are extracting from these projects generalizable lessons learned that can be used as we move the field of embedded pragmatic trials forward. As I'm talking, I realize that I didn't actually admit to you that in PakoreNet, I am not only part of the operations center and part of the coordinating center. I lead the distributed research network operations center. So I'm the person. If you have a beef with the PakoreNet common data model, I'm your woman. You can talk to me afterwards. I have responsibility for that group. And in the Collaboratory, I am one of the co-PIs of the coordinating center at the DCRI, and I chair the steering committee for the Collaboratory. So I realized that I didn't get the disclaimer in there about who I was and why I was talking to you about these things. So we are, as I said, we're charged with extracting generalizable lessons learned from these demonstration projects. I am part of the coordinating center and the steering committee. Unlike any other initiative that I've been involved in, the NIH to say that they are a partner is an understatement. They have created, and we have created with them, a very open environment for sharing of what is not working, and then figuring out how we take what is not working and package that up into papers, into presentations, into calls for or suggestions for even regulatory activities that can happen to make it easier to do this kind of work. It's been truly a fantastic partnership with them. And again, really focused on creating generalizable knowledge. And the way that works, we have these cores, these working groups or these cores, each of which led by an expert or a pair of experts in the area. The biostats and study design core is circled here. Demonstration projects talk with the experts on the core about the issues that they're having, and what the core does. They're tasked with really helping solve problems, right, to get these trials off the ground and make sure that they work, and also kind of coalescing what the themes are, what the issues are. So, the biostats core realized early on that when we're talking about embedded pragmatic trials, group randomized trials that's where it's at, right? And there are a lot of interesting statistical issues that come into play with those. So our biostats core has been writing papers, doing simulation studies to really inform the underlying methods that are needed for these trials. So we publish, our cores publish, our demonstration projects publish. We also have a knowledge repository and living textbook called rethinkingclinicaltrials.org. I'll show you a screenshot of that, where we push things we learn that don't quite rise to what might go into a peer-reviewed publication. It goes there. There's sort of nothing left on the floor in terms of what we've cut and decided not to share. We put everything somewhere. And then every Friday at 1 o'clock, We have a Grand Rounds, that is a WebEx hosted by, usually by the coordinating center, and we invite people from all around to talk about the work that they're doing that is in this realm of embedded pragmatic clinical trials. And we define that pretty broadly. So we've had some phenomenal informatics talks. We had someone from Flatiron on a couple of weeks ago. We'll soon be starting to go through the next round of hearing from the next round of demonstration project trials that have been funded. So it really is a great way to spend a Friday lunch, just on your phone, on WebEx. We currently have, this is a little bit outdated. This is the initial round of demonstration projects. Although common fund projects are only supposed to last a maximum of 10 years, the Collaboratory managed to get some additional funding from the Common Fund for beyond those 10 years. And more importantly, many of the institutes and centers came together to continue the funding of this, which is, I think, an indication of both how useful the products and the work of these demonstration projects has been to the NIH, but also a strong signal about where NIH continues to expect to go in the future, right? Their interest in embedded pragmatic clinical trials is definitely growing. So I won't talk about each of these trials. What I will say is that they span 12 ICs, so these are not all, heart, lung, blood or NIDDK trials, although we have some of those. Each of these, so they're funded with a one-year planning phase during which they work with the cores, they work with the NIH, they work with OHRP to work out the kinks and make sure that this trial that's imagined or that was proposed can actually be conducted. And then there's an implementation phase with, again, the cores and the community that is the Collaboratory supporting them along the way. Maybe just to touch a little bit on some of the trials, I mean, they really do range from the SPOT trial, which is looking at different strategies for suicide prevention, to Proven, which is looking at different approaches for end-of-life decision-making in nursing homes, to what's another good one? The Lyra trial, which is looking at whether providing clinicians with epidemiological data alongside when they're making decisions about whether to order images for low back pain, whether that changes at the margin what they order, if they know that a lot of times those images come back with incidental findings. That's been fascinating. So really quite broad, all of them, though, embedded in care delivery. We have a new batch of Collaboratory Trials that are just now being awarded, and they are as diverse as these, and we're looking forward to them. Over almost 900,000 active subjects. This number will go quite higher with the new trials that are coming on. And as I mentioned, we put everything we know, everything we learned somewhere. It gets published, it gets put into rethinkingclinicaltrials.org, and we really have been committed to making sure that, again, we're just not leaving any lessons learned on the floor or hiding them. We talk about the warts. So those are, both of those initiatives have consumed a little bit of my time over the last 5 years. Not all of it, but a little bit. And they have given me the opportunity to really think about, what it's like to work in this real world, right? The real world in which we work, and maybe how we might need to think about making that working a little bit better in the real world. My first observation is that really doing research in the real world, it's really hard work, and it's hard work for a couple of reasons. First of all, the systems in which we're working, they're complex, they're heterogeneous, they're constantly changing. This is actually a slide, a cartoon that Jerry Jarvik used in one of his Grand Rounds presentations, and I really love it, right? It says, the great Zeffirelli's chair worked a lot better in controlled conditions. And that sort of encapsulates our experience with these pragmatic clinical trials. Like, it was a whole lot better on paper, right, than it is in practice. Incentives are often not aligned at all. And I won't say that it's worse now, it's probably just different now, but as we move from this fee-for-service world into value-based care, I think there are even more incentives that are misaligned. So finding those questions, those opportunities, those partnerships where we're all kind of pointing in the same direction and we can use that to answer questions and generate evidence, I think that's one of the real tricks we have, and is what makes this particularly challenging on any given day. I already alluded to the challenges of actually getting results into practice, and although I think we are maybe understanding better what some of the factors are and how to speed that up, we still aren't turning that crank very quickly. So that's tough. I've already talked about the fact that the evidence base for what we do is lacking. I think evidence base for how we generate evidence in the real world is practically non-existent, right? We present the results of our trials. We do that, we're doing a much better job about that. But do we actually talk about what we did and how we got that done? I mean, I think one of the most valuable things about coming to meetings is that you sit around the table and you talk about your war stories. And you're like, oh, man, we tried to do that and it bombed. Did anyone write that up? No, right? We don't. We share it, we talk it, and then probably somebody at Duke is doing the same thing you did because they didn't know that somebody else tried that. They thought they had the brilliant idea. So I think figuring out how we as a community can start to talk about that and use things that are similar to rethinkingclinicaltrials.org, but use platforms like that to talk about, hey, we tried this is what didn't work, here are what some of the issues are, and maybe this is what we need to think about the next time. Another thing we don't do very often is actually evaluate what we've done and whether it worked. I had a great lunchtime chat with Bimal about this, right? When I asked the question earlier about clinician engagement and he answered and mentioned evaluation, I told him you got bonus points for that because that was actually the second part of my question, right? Are you evaluating what you do? And when it doesn't work, do you report that? And then do you figure out how to undo what you did? I mean, it's hard work. I talked about reporting what doesn't work. An observation that I had early on, probably in the work with PakoreNet, is that there are some amazing experts in each of these areas, right? Clinical research, informatics, care delivery, and early on in that initiative and in other initiatives that I've been a part of, I recognized wow, all of the expertise is there. But there really aren't very many people who are facile working at the intersection of all three. One of our colleagues in the Collaboratory, Greg Simon, who is always good for a really good quote, made this comment, and I think it's apropos to this issue of there not being that many people who understand the perspective of the other. And what he said is that often the researchers have this tail wagging the dog problem. If we think it's a good idea, we assume that the healthcare delivery system is going to be like, yeah, that's a great idea. But we have to remember we are the tail and the healthcare system is the dog. So we have to understand those other perspectives. We have to be in the middle of that triangle, not entrenched in our own perspective. I made this early on in PakoreNet. Rob Califf was at the time the PI of the coordinating center, and so I was spending a lot of time traveling back and forth to Washington with Rob. And I made this observation to him, and I said, it's like the Bermuda Triangle. There's just like nobody there. And Rob, for those of you who may know him with his southern drawl, said, you know, I think if you're going to get people there, you might not want to call it the Bermuda Triangle. But it stuck. It stuck. Stuck, and I even put a picture of the Bermuda Triangle there. So when I was trying to figure out, like, why is it that we don't have people who are right there in the middle? I thought, well, maybe it's all about training. Maybe we just don't train people to think that way, right? I was trained as a health services researcher, and I learned about informatics. I learned about care delivery along the way, but maybe if there were just more rigorous cross-disciplinary training, that would do the trick. And so, you know, I did a literature search, and really quickly realized it's probably not that, you know. So great paper, 15 years ago, right, from Ken Mandel and Tom Lee, talking about what needs to happen in terms of informatics and health services research training. Chris Forrest, right? Health Services Research Doctoral Core Competencies, that paper talks specifically about these things, right? So we're thinking about it. I think we're probably training our graduates to actually do this work. We do in epidemiology. I was hoping almost that it was just a training issue, because that almost sounds easier, right? Like adding a few courses, and along the way we've created people who are really working at the intersection. The bottom line is I don't think it's that. You know, it's possible, though, that there's something more that we need to do. I mean, this is a really good paper that came out a few years ago, and they pointed out that you know, there's really little work that's focused on the skills and knowledge needed by people who collaborate with informaticians but are not themselves informatics professionals. And that kind of got me thinking, you know, how much of this is about training and how much of it is really the way that we work with each other. And I began to think it might be more of that. I'm going to move through that. So my conclusion was that cross-disciplinary training is necessary, but it's not sufficient. And we really do need to think about how we work together and make sure that we're working together in ways that enable us to really address that grand challenge that I talked about early on. And so now I'll sort of wrap up by talking about my observations about how we can work together in the Bermuda Triangle, that probably everyone in this room says, yep, that's exactly where I sit every day. So the first rule, my rules for working together in the Bermuda Triangle are here, and I'll talk about each of them briefly. Being clear about the questions that we're asking, making sure that we prioritize data curation, making sure that we know the standards and use them, the importance of workflow, not oversimplifying anyone else in that triangle and overcomplicating ourselves, and maybe most importantly, resist the temptation to swim back to your corner. And these are not all of my original ideas. These come from really the experiences of working in the Collaboratory, working with those investigators, talking with my PakoreNet colleagues, and doing a really, what I say there is an unscientific survey of a lot of my friends and colleagues. So first of all, we have to be really clear about the question that we're asking. And you know, this is actually a quote that I attribute to Keith Marsolo, whom I work very closely with. It's like, there is no research question that requires everything in the EHR. And when somebody comes to me and I say, what do you need? And they say, well, just give me everything in the EHR. What I know is that they do not have a research question, right? And so for those of us who are researchers, like, don't start with the data ask. Start with the question. Be clear about what you're going to answer, and be clear about the question and what you're going to answer, and let that drive the data that you request, not the other way around. It's also not about your method or your tool, right? Now, you know, 5 years ago, 7 years ago, I would have referred to inverse weighted probability, inverse weighted estimators of inverse probability treatment weighted estimators, right? I've written about this. I just can't speak about it in one string. I would have talked about that and propensity score methods. Now, what will I talk about? I would say machine learning, right? Every question is answerable with machine learning, or so we're led to believe. It's actually not, right? Like, what is your question? And what approach, what data, what approach, what will generate an answer that is reliable and robust? That should be where you go. Inform those methods inform whether and how the question can be answered. So once you've identified your question and figured out how you're going to do it, make sure that the data that you have and the tools that you have in your toolbox will actually allow you to answer the question. But again, don't start there. Start with your question. And make sure that you frame your question with the implementation in mind. I think that's the takeaway from the 17 years that it takes to get anything into practice, right? It is oftentimes we start with a question that is interesting to us, but a question that if we answer, no one else would immediately say, yes, I needed that answer and let me use it today. So start with that question. Prioritize data curation. And here I will smile at my colleague Mark, with whom I worked for a long time on the Sentinel initiative. And this is where the action is. It's not. I think in this paper by Donahoe, he says 80% of the effort devoted to data science is expended by diving into or becoming one with the messy data and learning the basics of what's in them. It's really not the glamorous work, right? And it's the work that probably all of us do and all of us are asked to do. I submit it is the most important work that has to be done when we're using data that are collected for anything other than what we're using them for. It's all about the data curation. Missingness matters. We see that in any sort of health system related analysis where we know what we know and we really don't know what we don't know because they don't come back to us all the time. That leads to incomplete outcomes ascertainment, confounding, bias. It's really important, though, not to make those data curation decisions in a vacuum. We have many sort of tales, if you will, that have come from our collaboratory projects of, decision making about data that's happening upstream, or is it downstream? Upstream. And by the time the data are used, suddenly they've sort of become something that they never were originally. And so making sure that those decisions that are made contextually so that the data can be used as we're intending them to be used. I'm a firm believer in leaving data in the most granular kind of usable form and then constructing your variables for purpose and figuring out how we can be efficient at doing that rather than, the be-all, end-all data set that really doesn't answer anyone's question, but we spend a lot of time and money creating it. I think this was lesson one from our early days in Sentinel. The local expertise is absolutely critical, and you have to pay for it. Don't just, if I'm collaborating with another set of institutions, and we're using their data, or their data are part of this, better have their data people at the table and talking with us and informing the way that we use those data because they know so much more about that than I do. Standards, making sure that we know and we apply them. These data standards really do allow us to build things at scale and replicate and duplicate. At the same time, we cannot confuse existence of data standards with adoption. I can't tell you how many times I've been in these really awkward conversations where somebody will say, well, there's a SNOMED code for that. Why don't we just use SNOMED? Like, do you know that nobody is collecting? Where is that going to come from, right? So again, making sure that we're very clear about we understand what's being used versus what has been created. Also know and apply the standards for good, solid research and study design. Do not skimp there. So think about confounding, think about bias. If you're doing a comparative study, do a new user design, use that, right? We've learned a lot of things from the Women's Health Initiative, and that's a pretty big takeaway, right? Prevalent users is not getting you the answer to the question that you think you're asking. And then make sure we have complete outcomes and demand complete outcomes. And also know and apply the standards for software and tool development, because at the end of the day, what we want is for what we create to actually be a solution for somebody else. I really don't think any of us just want to create the next shiny, bright object that somebody else looks at and says, well, that's cool. What we really want is to create a solution that solves other problems. I almost took out this bit because I thought I'm talking to people who know this better than I do, but I will say it anyway in the interest of being complete. Pay attention to the workflow, right? Understand why the data were collected that you're using, and be honest about the fact that they weren't collected for you. They weren't actually collected to answer the really awesome question that you have in mind. And it's probably pretty likely that something about those data, something about the way they've been collected, it's changed over time. The more you know about that, the more you can draw appropriate inferences from your analysis. One of my colleagues in the Collaboratory, Vince Moore, who leads the Proven study, I think when he first started doing work, these embedded pragmatic clinical trials, like most of us, just assumed that a lot of things would happen, right? Because it's an interesting question, it's interesting, they really do want to know the answer, but he realized pretty early on, you can't just assume this, right? You have to actually change what happens on the floor. You have to understand what happens now and have a plan for how you're going to tweak that so that the work that you're doing can actually take place. One of my other realizations along the way is that one of the problems in this Bermuda Triangle, or the intersection of those fields, is that we often have a tendency to oversimplify what other people have to do and overcomplicate what we have to do. So, as an example, it's super easy for you, Mark, to just pull that data set for me. The really hard part is for me to analyze it, right? That's the hard part. And in fact, it's a lot of work for everyone. And as long as we have to understand that. I think we do ourselves a disservice when we talk in a lot of jargon. We researchers do it. We use terms that we don't identify. My informatics colleagues do it all the time. Clinicians have a PhD in jargon, right? So we do it all the time. Let's try to dial that back. Give jargon-free explanations. Use a common lexicon. And remember that it's actually everyone's doing hard work in this, and acknowledge that and respect that and get the work done. And recognize that we're building relationships for the long term. These are not, we want to be able to not just answer a question and then build another set of relationships. We want to build relationships and answer a lot of questions with people that we work well with. I realize I didn't put a slide in for my last point, so I'll make it without a slide, which is the other rule is don't resist the temptation to swim back to your corner, right? I think many of us operate in the middle of this intersection. And when it gets really irritating, or when times get tough, we're just like, oh God, get me back to the health services researchers. I can talk about the things we talk about, right? And I would say resist that temptation, because the only way that we really will tackle the challenges that we need to tackle is if we keep at it and keep working together. So I do want to acknowledge the many people who contributed to my rules, and I would be happy to answer any questions you have.